My name is Associate Professor Prof Hazratwala. I'm an orthopedic surgeon practicing in Townsville, Australia, currently both in the public and the private sector. I graduated from medicine at the University of New South Wales in 1997. I spent the first 7 to 8 years of my medical career practicing and working in New South Wales as a junior medical officer. And then I got on the training program for orthopedics in Queensland, and I have been in Queensland ever since. I have had experience working overseas, including Japan, Italy, Germany, third world countries like Papua New Guinea and Fiji. I am going to discuss today the reforms that are required to make healthcare sustainable in Australia. In the current form, which is Medicare and the health-funded private medical system, there are deficiencies that could be improved upon. I am also going to talk about the structure of the current private medical health sector and how surgeons and doctors integrate within the private health sector. I will initially start off talking about the public and the private health system currently as it stands, and move on to talk about the private health sector and the deficiencies within the health sector, and then lastly talk about the Weststate Private Hospital. This is a initiative that I'm involved in as the founder to develop a 53-bed private hospital in Townsville, mainly a surgical hospital, and we will try and work on the 3 E's of our mission statement. The first being the experience of the patient as they journey through their health care through the Weststate Private Hospital, the efficiency of the system, which is the back of the house, to make sure that the private health sector is sustainable. And lastly, engagement. We will endeavor to engage all the stakeholders, including the government, the health funds, and the industry. So let me begin by discussing the current state of the public and the private health sector. One of the major issues that the Australian healthcare sector faces is that there is a distinct disconnect between the service providers and the owners of the infrastructure. Talking about the public health sector, the accountability factor for the surgeons and the physicians does not exist. What I mean by that is the doctors are engaged and are contracted by the public health sector to provide a service. However, the service is provided without any accountability of the outcome of the patient treatment. This is a major issue. This also applies to the private health sector. The private hospitals and the public hospitals both do not have a patient outcome monitoring system. So therefore the value of the health dollar is unknown. If you define the definition of value of the health dollar equates to the amount of money spent per case and the outcome of the case. If you don't know what the outcome of the case is, it's very difficult to know the value of the health dollar. A surgeon may operate on a patient, and good or bad, we don't know. So when you talk about the amount of work done or the productivity of the public health sector, we talk about activity-based productivity. We know how many cases we did, but what is the general outcome of those cases? How many cases were reoperated on, and how has the patient done? No hospital in Australia currently collates that information. Therefore, it's very difficult for the health sector to be efficient and be progressive in trying to improve the quality of care. The accountability upon the people working within the health sector is significantly lacking. I could give you multiple examples, having worked in the health sector for the last 35 years and last 15 years as a orthopedic specialist. Now let's talk about the private health sector. In the private health sector, the infrastructure is owned by major corporates, being companies like Ramsay, Healthy Care, Healthscope. Now, these companies invest in owning the hospital, and they are responsible for providing the infrastructure. Surgeons and physicians do not have any contract with the private health hospital owners, and they are basically responsible for looking after their patients. The private health sector owners, as I mentioned, the major corporates, they spend a lot of time trying to entice and engage with the surgeons and physicians to come and work in the hospital. This is a revenue generator for them. So when you look at the system of the private health medicine, there are three moving parts. The first part is the health fund, which is the purse string of the private health organization. If health funds did not exist, the private health system would not exist, because the total funding comes from the private health funds. So the health funds are responsible for paying the bills. The health funds independently negotiate a fee for an episode of care with the private hospitals, and the surgeon has a medical benefit schedule, according to which the health fund may set a rebate for the surgeon to be paid. But in most cases, the surgeon may choose to charge over the set rebate, which is either known as known gap, which means that the health fund has allowed the surgeon to charge a specific amount of money per case to the patient outside of the rebated fee, or the surgeon may choose to charge above that, which could be AMA or even more than that, which is basically the out-of-pocket expenses that we speak of. So the issue here is that the surgeon is enticed or encouraged by the private hospital system to come and work in their hospital in order to bring revenue to them, which is independently paid by the health fund to the private hospital. The surgeon chooses to work at Hospital A or Hospital B, and there's a competition between Hospital A and Hospital B to bid for the surgeon's work. Most of the time, the surgeon may choose to work at both hospitals or maybe one, depending on what sort of deal he has been provided with. So in this situation, the surgeon will go to the private hospital, he will use the services without having to pay a fee, without having any accountability towards the infrastructure, without having any accountability towards the private health as how much they are paying to the private hospital for him to perform the case. Let's take an example of an orthopedic case. If the surgeon were to operate at a private hospital and he decides that he wanted to do a case with a prosthesis X, but halfway through the case he changes his mind. The prosthesis has been opened. Unfortunately, he decides that he wants to do prosthesis B. In this situation, the cost of the prosthesis A that has been opened has to be borne by the health system. There is no accountability on the surgeon to have to repay the cost of that prosthesis that has been opened. That's talking about the prosthesis that has been borne by the private health care. However, if the surgeon were to be inefficient and, argument purposes, uses 50 gauze packs, now, that is excessive. However, there is no accountability for the surgeon why he or she is using 50 packs as opposed to surgeon X who only uses 5 packs. This is the distinct lack of accountability and the blowout in the health costs. Why is this happening? The reason is that the data that is required to analyze and feed back to the surgeon is non-existent. Most hospital systems currently work on a manual, paper-based medical record system, and all the information within the theatre environment is also collected manually. The prosthesis that has been used has a manual recording system where the stickers from the prosthesis box are put on a piece of paper, and the piece of paper is then delivered to the account officer within the theatre complex, and the account officer logs that into a computer system, which then goes to the billing department. Therefore, if you look at the billing structure, it is dependent on the nurse in theatre making sure that the total number of prostheses that have been used has been translated onto that piece of paper with the stickers that come with the prosthesis box, and that piece of paper has been delivered to the billings officer within the theatre environment, and then goes to the billings officer who sends the invoices out to the health fund. There is so many points within this equation that the system can fall apart and the bills may not be sent through. Same concept applies to consumables. If consumables are used and they are not replenished, then the next case can be delayed or cancelled because the consumables haven't been ordered. Once again, this is because there is no digital system within the hospital to capture this information. There is an inefficiency driver that's inherent within the health system that potentially could cripple the health system moving ahead. This is talking about the private health system. Now, going back to the public health sector, the issue there is accountability within all stakeholders: surgeons, nurses, anesthetists, and even the bookings officer. I'll give you a quick example of a case that was cancelled last week when I went to the public hospital. I have an appointment to work 1 day a week at the public hospital. I had a full day operating list. So I turned up at 8 o'clock in the morning and the patient hadn't turned up. Looking at the patient history, the bookings officer wasn't able to contact the patient for 2 weeks. The anesthetist tried to contact the patient over the weekend. He was unable to contact the patient either. It was assumed that the patient will turn up, but obviously the patient has been booked on the system, but hasn't been informed that his surgery is going to take place on a Monday morning. I turned up, the anesthetist turned up, the nurses turned up, the company rep that with the all the equipment and implant turned up, but the patient wasn't there. It costs $147 per minute per theatre time, and if theatre time is wasted, therefore you can work out the economics of it. A knee replacement costs the health system anything up to $36,000. This is a figure that has been published by the private health industry. And out of the $36,000, $11,000 is the rehab cost of the episode of care. So you can see here that there are inherent inefficiencies within the public and the private health system that lead to a model that potentially is unsustainable. Now let's go to the second part of my talk, which is the interaction between the surgeon and the private health organization and the private hospital. I've quickly touched on this in a part one of the dissertation. However, I'm going to elaborate a bit more on this, as it is very important. There is no contract between the surgeon or the physician working in a private hospital. No hospital has a binding contract for any surgeon to come and work there and do a specific number of cases. This is because the surgeon does not have a skin in the game with the private the private hospital. The private hospital is owned by the corporate. The surgeon merely takes the business to the private hospital. As I mentioned before, the remuneration package is also separated between the private hospital and the surgeon or the physician. The health fund pays the private hospital per episode of care on a pre-negotiated basis, and the surgeon also gets paid by the private hospital once again on a pre-negotiated basis according to the medical benefits schedule. There is a distinct separation of allegiance, alliance, and understanding between the three moving parts, which are the health fund, the private hospital, and the surgeon. If you were to compare this situation to a retail business, in no other business environment does this model of care exist, and that is because that in order for a business to be sustainable and to flourish, there has to be an alignment or accountability actor on all people that work within the business. If you are a developer and you are developing a retail building complex, your tenants will have to sign a contract or a MOU that says that when the building is built, we will take 100 square meters at a rate of X, Y, and Z, and for a 5 or 6 year period. That relationship or that understanding does not exist in the medical sector. A surgeon will not sign any type of paperwork, contract, MOU with a private hospital because there is no need to do so. The surgeon knows that the private hospital needs his work to be able to be sustainable and make a profit. So he or she will wait until such time that he or she feels comfortable that the private hospital provides him or her with the facility they desire and what sort of deal they are going to forward the surgeon. This clearly undermines the efficiency drivers of the healthcare sector. The reason being that the surgeon or the physician does not have any accountability towards the private hospital. And the private hospital will have to have an expense module that is out of their control, in the control of their so-called non-contracted contractor. So if as I mentioned before, the surgeon may be inefficient, he may use 50 packs instead of 5, he may drop a prosthesis, he may use 100 liters of fluid to do a shoulder arthroscopy. That is all part of doing business. Hopefully that the hospital system can make up some money on a surgeon that is very efficient. The other major part of this equation is the outcome of the patient. There is no system that exists in the private or the public health sector that actually collects the patient-reported outcome measures. The only patient-reported outcome measure you will ever be able to get is from the individual surgeon if he or she has a research-minded practice. They will see the patient preoperatively, collect the outcomes or the outcome score, meaning the pre-op outcome score, and then over 6 weeks, 1 year, 2 years, 4 years, 10 years, whatever it is, they will collect the outcomes to see how the patient is faring after the operation that has been done. But this can be considered biased, so therefore an objective outcome measure has to be collected. So as you can see, I have just in these two parts outlined to you the inherent inefficiencies that exist within the private health sector. So now let me go on to discuss the Weststate Private Hospital initiative. This initiative is being formed by 3 surgeons, myself, Dr. Prof Hazratwala and Dr. Peter McEwen. Myself and Dr. McEwen are orthopedic surgeons, and Prof Hazratwala is a urologist. We are funding the operational aspect of this hospital, and Australian Unity is the landlord who has bought the project of Gion, who is our developer. There is a requirement from the Weststate Private Hospital operators, which is us, to fit out the hospital, and that will cost anything up to $23 million, which includes beds, theatre equipment, theatre lights, infection control equipment, computers, so on and so forth. We have gone to the banks and to other financial institutions in order to get funding, but as you can imagine, our business case looks very strong, but because we haven't been able to secure signatures of surgeons that solidifies our business case, there is a issue raising equity. However, let me talk a bit more about the Weststate Private Hospital and how it will facilitate efficiency drivers, how it will engage the stakeholders, and how the experience of the patient will be enhanced. So let's talk about the patient experience. What we intend to do is to fully digitize the hospital. The pillar or the cornerstone of this project is the $8 million EMR system, which is electronic medical record system, which not only controls the medical records of the patient, the clinical medical records, but it also allows us to collect information as the patient journeys through the hospital and also after they have left the hospital into the community. So this system that we have bought collects information on the patient preoperatively as to how they're doing, what the demographics are, what their comorbidities are, how sick they are, and what the actual problem is. Then as they journey through the hospital will have a fully digitized nurse call system, which allows the patient to experience interaction with the nurses and the doctors on a one-to-one basis. Every room will have a fully digitized iPad system which is connected to the nurse and to their surgeon. It'll be a dashboard-based system which the patient can order their food from it. They can order if they so wish a haircut or want to talk to their friends and family via Skype or WhatsApp, watch Netflix, watch Stan, whatever they wish to watch will be available to them. They will also be able to message and communicate with their physician, being a surgeon, in this situation via their nurse call system. We intend to have a menu system which is on demand, and we'll have a chef in-house to provide first-class treatment and meals for the patient. As they go through the surgical journey, and the efficiency drivers of the surgical journey are the EMR system, or the medical record system for the theatre complex. We have a fully digitized EMR system with a RFID for all consumables and implantable equipment that we will be using. So every surgeon that comes through the theatre complex and doing his work will have their consumables and implants itemized and easily sent back to the billing system, so there is no paper-based system. Going back to the ward, again, there is a total integration of the x-rays, pathology, the clinical notes, the nurse notes within one EMR system, which is also accessible via a handheld device, being an iPad or an iPhone or Android. Going back to the theatres, the RFID system detects what has been used within the theatre complex and does an order through our preferred industry provider to replenish what has been used, so there is no downtime for waiting for equipment or implants that have been used. So the system has an efficiency driver where there is no delay in what is required. This also helps with our accounting, where anything that has been used and is billable or is orderable is done simultaneously. Going back to our theatre staffing organization, most private hospitals currently work on a theatre manager who allocates nurses on their rostering system to different theatres, and nurses are made to work one day in urology, one day in general surgery, one day in orthopedics. That's an inherent inefficiency driver within the system. We intend to have a pod-based system. What that means is that we will have we have 7 theatres. Per theatre, there'll be a team leader, and the same nurses will be allocated to the theatre 24/7. That team leader will be responsible for looking after their nurse group, and they will be doing their own rostering. This allows for efficiency. What that does is every time a surgeon turns up to that theatre, it will be the same surgeon every day of the week, and the same anesthetist every day of the week will be in that theatre. So the team remains the same. So the team is aware of what the surgeon needs, what the anesthetist wants, and what the surgeon's preferences are. The rostering system will be done by the team leader, and they are accountable for the inherent efficiency of that particular theatre complex. That she reports to the NUM of the unit, who is responsible for growth of the theatre complex, not the inherent workings of the theatre complex. As in business, it is well known, don't work in the business, work on the business. So a highly specialized managerial position as a NUM of theatres will be working on the theatre complex to try and make the theatre complex more efficient by engaging more surgeons, by engaging more anesthetists, and making sure that the work is done in a timely basis rather than wasting time on rostering. So here are some of the more complex efficiency driver changes that we are putting in place for the Weststate in order to make the health system more efficient. The other concept of the EMR and digitization is the data. We will be able to collect data as to what time the theatre started, what time it finished, what was used, where the deficiencies were, and there will be a benchmark over time when the data is collected, and most surgeons will be fed back as to if they're efficient, if they're not efficient, where the deficiencies are. And we will be looking at the top-end surgeon or the top-end physician as to what they are doing and to try and institute those positive changes within our theatre complex and within our surgeon cohort to make sure that everyone uplifts their game to the best performing surgeon. We also have a group of anaesthetists we are engaging with to provide a 24/7 service for the hospital complex. So this will make it rather easy for all the nurses and the doctors to know which anaesthetist will turn up for their list on any given day of the week. Now, engaging with the surgeons and their fee structure. It is important to note that the biggest dissatisfaction currently within the health fund and the health fund membership is out-of-pocket expenses. The health fund membership across Australia is the lowest since 2003. It is 44% at present and falling. The health fund premiums are rising every year, and there is a significant distrust and issue within the community, as every time they have to go and see a surgeon or a physician, there is an out-of-pocket expenses after they have paid their health fund premiums for the year. Now, the reason for this is the MBS indexation hasn't taken place according to the CPR, so the surgeons and physicians running their rooms have to meet the CPR indexation that cost of running their rooms. They have to pay for a nurse, pay for a secretary, the rooms, the utilities, so on and so forth. Having said that, the out-of-pocket expenses can be significant in some states, and it has been well documented that there are mercenary type activities by some of the surgeon cohort, which obviously is unethical and not endorsed by the Weststate Private Hospital ethos. What we are trying to do is to be efficient in the back of our house, as I've mentioned before, and allow the surgeons to participate in a shareholding or a remuneration reimbursement type scenario. We have organized for all surgeons that work in the hospital to either have a shareholding or be incentivized by receiving a subsidy for their rooms rental within the Weststate Private Hospital complex, and they will be incentivized to work efficiently, and according to the revenue they generate, they may be entitled to some sort of a reimbursement for their work. This is an incentivization process, therefore it aligns all surgeons working within the hospital to have a similar type of ethics and ethos of efficiencies, making sure that the patients are looked after, the nurses are looked after, and overall the culture of the hospital is improved. I think putting these strategies in place will set the Weststate Private Hospital apart from its competitors, because most other hospitals are, as I said, corporate owned, and there is no relationship between the surgeons and the hospital complex. In this situation, although it's very difficult for us to get binding contracts with the surgeons, but there will be an incentivization process that will allow the surgeons to be engaged with the hospital and see the hospital as one of their own. In summary, there is a distinct deficiency within the current public and private health health sector, which is causing an unsustainable system within the Medicare and the private health industry. The membership of the private health funds is dropping due to the increasing premium and the decrease in perceived value of their private health insurance. In order to help the private health insurers increase their membership, we are trying to decrease the out-of-pocket expenses for the patients by being efficient and to allow the surgeons to pick up the loss of income if they were to no-gap the patient by a reimbursement package, because we intend to be more efficient and be able to drive a surplus that can be shared by the surgeon cohort in order for them to meet their income requirements. I hope that this little talk has been useful in understanding the current deficiencies within the public and private health sector and how the private health sector engages with the providers being surgeons and physicians, and how Weststate Private Hospital is going to help change the current state of private health medicine in Australia. Thank you.